Hi, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host of the Dean's Chat podcast. My guest today is a longtime leader in the podiatric profession, Dr. Jeffrey Robbins. Dr. Robbins is the National Podiatric Medical Director, Specialty Care Services, VA Central Offices in Washington, D.C. He is responsible for national policy, program development, and oversight of podiatric services, residencies, and fellowships within the VA. Dr. Robbins graduated from The Ohio State University, OH,
IO,
and received his DPM degree from the Kent State University College of Podiatric Medicine. He's also currently a clinical assistant professor at the Case Western Reserve University School of Medicine. Welcome to Dean's Chat, Dr. Robbins.
Thank you so much. I much appreciate being on your show.
No, it's great to have you here, Jeff. We do go by fireside chat kind of vibe, and so Jeff and Jeff will keep it super easy. How's that sound?
That totally works for me. I didn't change my first name to Doctor.
No, me neither. All right, I like that. First thing I want to do, Jeff, is thank you for your service within the VA. You've had an incredible career, and all of us have looked up to you for so many years. Thank you.
My pleasure. Thank you.
So I'm going to just change the format a little bit, and I'm going to talk additionally about some of the service that you've done within the profession, because as I was going through your CV, I just didn't want to start reading stuff. I thought we'd talk about it during the interview. So the first thing I wanted to ask you about, you're the president of the board of directors at Kent State University College of Podiatric Medicine.
Yeah, they have a clinic board, not of the university, but of the College of Podiatric Medicine. They have a clinic board, and I just became president of the clinic board in June. I took over for Dick DeBacco, who did a phenomenal job over a 10-year period. And so now I'm getting to use some of the education component of my career that I haven't up to this point really had an opportunity to do. So I'm excited about that.
That's a great opportunity, and giving back to your alum as an alum. That's great. How about the next one? You and I together serve on the board of directors of the American Association of Colleges of Podiatric Medicine. You are definitely one of the longstanding members of that group.
Yes, I've been involved since the early 80s, back when we did CLE, which is the Committee on Entry-Level Expectations. That was a document that we developed to standardize podiatric medical education that ultimately was the forebearer of what we have now, which is a standardized program you would know better than anyone running a college, one of the most excellent colleges, I might add. And I don't have to say that because I'm on the board of the Ohio College, well, now Kent State. But that really led to the development of a single track podiatric medical education that had a standardized amount of education that all students got, and then so that the product that we develop after the residency program is virtually the same level of competency, the same level of training, with some exceptions. Obviously, some of the rear foot and ankle reconstructive surgery, that's sort of an added certification, but everyone has the same basic training, and that was a long time in developing, and it has served us well as a profession, I might add.
There's no doubt, whenever I look at the AA or AACPM, they've got their tentacles in so many things over the history of the profession, and certainly even the Council of Faculties, Council of Teaching Hospitals. And I've been a part of it 13 years now, and I've always enjoyed working with you on that board, and always look to you for advice and words of wisdom, certainly with the rest of the team. So thank you. You're also on the board of directors of the Council of Teaching Hospitals.
Yes, absolutely. So the VA is the single largest provider of postdoc education, actually of doctoral education as well, because we serve probably 70% of the students of podiatric medicine do a rotation through the VA in one form or another. And I will tell you that it's translated, we just found this out, to 70% of the podiatrists in the podiatry service in VA had some training in the VA program, which is one of the missions of the VA, is to train the next generation of providers for both the VA and the country. So the Council of Teaching Hospitals I've been involved in 26 years, maybe a little longer than that. And we have gone through all of the crises, the residency crisis in the 80s, that in the 90s that we have solved. And of course, now we have enough programs that every student can have a residency program, which certainly wasn't the case when I graduated, and I don't think when you graduated either.
No, in fact, I remember vividly, just as recent as 10 or 11 years ago, we were having some challenges, and we were able to, as a profession, get together and solve that problem so that everybody has an entry-level residency opportunity once they graduate.
Yeah, and that has worked well for us professionally, as in terms of how we're viewed by the rest of the medical establishment.
Well, I know that it's been a tremendous benefit for the students, Jeff. I mean, it's so important that when they go through 4 hard years of podiatric medical school, that at the end of the rainbow, they've got a residency opportunity. So it's really served our profession well.
Yeah, it has certainly reduced the anxiety of getting a program. I know when I graduated, about 50% of us got residency programs, and I'm sure that was higher when you graduated. But still wasn't 100%. But now they will get a residency program as long as they pass their boards, and that's just tremendous. I mean, these are things that those of us who have a long history in the profession work so hard for, and of course, it is the matter of course for newer students in the last maybe 10 years or so. So that's good. I'm glad we were.
It's interesting because our medical and osteopathic colleagues, they have about a 92, 93% entry-level position. So I think it's great for our profession. It served us well. You're also on the editorial board of JAPMA. I mean, your history of writing papers is incredible. Tell me about your relationship with JAPMA.
So Warren Joseph, who has done an absolutely phenomenal job with the journal over the last, I think it's 20 years. I think it might be more than 20 years. Asked me to be part of the editorial advisory board, which I, of course, was very happy to do. And I think that it has also served the profession well. Now, I know that there have been some criticism about the number of papers that are coming out of foreign countries in the journal. The fact of the matter is that if you can't expect them all to be from this country, and not only that, but a lot of the research that's being done in places like Australia and New Zealand and Europe and in the Far East are very, very, very high quality publications. And so we should make sure that we are publishing high quality. And journals are one of the last bastions of totally objective viewpoints. And so a good paper is a good paper, regardless of where it comes from. That said, I do encourage the folks, when I have the opportunity to do that on the board at Kent State, I do encourage the faculty to continue to publish those articles and to continue to do that research, because it is important that we do that research and not just get hung up on either training students, residents, or treating patients, but that we give back to the medical community and to the literature. I think it's really important. And I've tried to model that behavior. Hopefully I've been somewhat successful.
I've tried to, but there are some really prolific authors and publishers in our profession that have just really advanced our profession really well. You know, I tell our students, if you get involved in research and you do a poster, you do a paper, we submit to JAPMA, it really gives you a leg up when it comes to residency pursuit too, because the residency programs want students that not only could they handle the curriculum, but they're also writing papers.
Yeah, exactly.
Very good. Well, let's turn the clock back a little bit, Jeff. When you were at Ohio State, you majored in zoology, if I'm not mistaken.
I did zoology and also sociology.
How'd you make the jump to the Ohio College of Podiatric Medicine?
So I was in a fraternity at Ohio State, and the advisor was a dentist. And I spoke with him because I wanted to go into some branch of medicine, but I also wanted a life. And so he suggested that I visit one of his buddies who was a podiatrist in Columbus, which I did. I visited every health professional that I could find. And what I found was that, when you go to a primary care physician, you go with a bellyache. Most of the time, you're leaving with a bellyache, maybe a prescription. The dentist, the same thing. No one was happy to see the dentist. No one's ever happy to see the dentist. They're always afraid they're going to hurt them, and usually they're right. But the podiatrist was different. Most of the patients, not all of them, but most of the patients came in some kind of discomfort and walked out in comfort. And that immediate gratification really spoke to me. And so that was something, and I figured this is something I should pursue. I pursued it. I actually, and to set the record right, I didn't graduate from the from the Ohio State University. I went 3 years and was accepted early to podiatry school. And I had all my requirements, and I was actually waitlisted in the summer, and then I was accepted. And so I didn't have to complete my senior year. That happens now, but now usually the institution that you go to, which would have been Kent State, would have given you that bachelor's of science or bachelor's of art. It wasn't that way when I went there. So I went 3 years and was accepted early, and got my DPM from the Ohio College of Podiatric Medicine, which is now Kent State University College of Podiatric Medicine.
Right. It's funny. Here we are, 40 years later, and when I'm interviewing students, they're giving me the exact story that you and I experienced. You go and you shadow a doctor of podiatric medicine. They're enjoying what they're doing. They've tailored their practice to what they like to do. And you leave there saying, oh my gosh, that's something I want to do. That's why shadowing is so important.
Yeah, absolutely. It's essential. It's essential.
No doubt. So you went off to Philadelphia for your residency.
I did. St. Luke's and Children's Medical Center with the great Art Helfand.
Very good.
Still alive, who I am still in touch with. Art is one of my mentors. I publish with Art a lot in geriatric journals mainly. We published several papers and several book chapters together, and I still keep up with them. It's still we're still lucky to have him around, and he's still very, very active, by the way, in the geriatric community in the Philadelphia area.
Very good. Well, you kind of gave me a nice segue into mentorship. It seems like everybody in our profession that is assumed a leadership role has mentors. Obviously, Dr. Helfand was one of your mentors. Any other mentors you'd like to talk about?
Len Levy was another mentor. He was absolutely phenomenal. I mean, he was somebody who I never got bored talking to. He was always climbing up that ladder for the next thing. He was always trying to predict the future. It's from him that I learned how to predict the future. Now, what I mean by that, of course, is that reading tea leaves. You can see what's developing over time, and you can see what's the next thing is going to be, and you can redirect yourself to that. I've done that in the VA, but Len was the one that did that. He was a visionary. Marty Mussman. Marty Mussman was at that time, the director. The title has changed since then, but he had my position for several years between, I think, 87 and 97. So he was there for 10 years. He was another mentor. And, he really moved the VA, he moved the podiatry service in the VA forward. I stood on his shoulders and always appreciated his help and his wisdom and his guidance.
Fabulous. Let's talk about the VA a little bit. How did you evolve into the role you did in 1997?
So Marty said to me at the time when he was contemplating retiring, and Marty was a special guy. He was a special character, as Art and Len and Marty and that whole group. They were sort of a cohort, if you will. They didn't ask you, they told you. you're going to apply for this position. You're perfect for this position, and I want you to apply for this position. And I said, well, I was at the Ohio College at the time. I was a department chairman. I was publishing. I had grants from HRSA, and I was very happy. And he said, I appreciate that, but we need you here. You need to do this. And it was that purpose-driven concept that always appealed to me. So I said, all right, well, I have nothing to lose here. I love what I'm doing now, and this would be a new opportunity. And here was the most important part of that. I realized, much like being in what you're doing as dean and what I was doing as a department chairman, I had the opportunity to make a difference. It didn't mean I was going to. What it meant is that I had the opportunity to do that. And I thought this position also, I said, it's an opportunity to really make a difference in the lives of veterans. And again, not that I was going to, but that I had the opportunity to do that. And that's not offered to many people. So I applied, and here I am 26 years later.
That's great. So let's talk about the evolving podiatric services in the VA over that time. What was it like in 1997 compared to what it's like today? If that's a fair question?
Oh, that's a very fair question. So in 1997, the relationship between podiatry and orthopedic surgeons was not great. And in fact, I was field-based in Cleveland at the time. I was chief of podiatry there, which I maintained, as well as being national director. We didn't have surgical privileges in my own facility. And so I went to the chief of surgery, and at the time I brought in one of the surgeons from the Ohio College, Bonnie Nicholas, who was just a phenomenal surgeon, and also well-respected, highly published, very talented. And I said to the chief of surgery, which at that time was CARE, and we need to make this a surgical program. We need to provide full-scope podiatric practice. The chief of surgery wasn't going to touch it with a 10-foot pole. He said, go talk to the orthopedic surgeon, which I did. And they said, well, let me talk to my group. So they came back and they said, we decided no. I said, can you tell me why? Yeah, well, number one, we don't need any more foot surgeons. We have enough. And number two, we don't want to compete for OR time. To that, I said, well, doesn't vascular surgery do carotid arteries? Yeah. Doesn't neurosurgery also do carotid? Yeah, they do as well. So the argument that you have too many really doesn't hold water. And number two, we would be more than happy to allow your residents to scrub our cases. You can imagine how that went over. And so the answer is still no. And I said, I appreciate that, but I'm going to continue with this quest because this is really for veterans. This isn't about podiatry or orthopedic surgery, it's about veterans. So I went back to my staff and I said, they said no. But here's the good news. We're going to get surgery to do. I want you to identify all the patients who need it, and I want you to refer them to orthopedics and just keep track of them. And this includes major diabetic foot infections, all of that stuff. They did. 6 months later, I collected the data, analyzed the data. I went back to the chief of surgery, went back to the chief of orthopedics. No. Then I went to the chief of staff. And I said now I didn't tell the orthopedic surgeons the data that I had. They should have known. I went to the chief of staff and I said to the chief of staff, at the very best, we're delaying care. And at the very worst, we're denying care and it's costing us amputations. And I laid the data out in front of them. And literally the next day, we had surgical privileges.
Wow. And was that the case across the entire country, Jeff?
No.
Okay.
No, it was a case-by-case basis.
Okay.
And so and anyone who knows me knows that one of my sayings is, I don't get mad, I get data.
There you go.
You can't upset me, especially if you're trying to upset me. the process is keep your eye on the ball, keep your eye on what you want, and continue working toward it. Orthopedic surgeons came back and said, okay, now we're going to define what those are. And I said, no, that ship has sailed. Doctor that she has currently at the local hospital, which includes diabetic foot infections. And so we started doing that work, and she started training resident after resident. We have some outstanding residents that graduated from the program. But something really curious happened about 3 months later. And that is the chief of medicine came up to me and said, thank you for doing that. And I was a little curious. Why are you thanking me? He says, you don't know what was going on. When diabetic foot infections came into the ER, they didn't call it podiatry. We had no idea. They called medicine. Before they called medicine, they called orthopedics. So orthopedics said, there's pus here. We don't deal with that. So they would call vascular surgery. Vascular surgery would come in, there's a pulse. This isn't for us. So they would call medicine. They would put him on the medicine floor. They would give him IV antibiotics, let him demarcate, then they would have to amputate. Since that time, number one, they weren't getting these calls, these frustrating cases. And surgery was saying, our amputation numbers have gone down precipitously because you guys are handling this when it should have been handled at the beginning.
There you go.
So this was how I advised other chiefs of podiatry around the country how to approach this. You don't approach this by banging on the door. You approach it from a patient standpoint. This is the best interest of the patients. This is what this is about. This has nothing to do with any kind of professional prejudice or anything like that. And so we were able to change that paradigm. So today at the Cleveland VA, the orthopedic surgeons refer the foot and ankle cases to the podiatrists because their relationship is outstanding. And it is collegial, which is the way it should have always been. But sometimes you need to push a little bit.
Sure, absolutely. That's a great story. And you know what? I see that story all over the country. I see it even in other countries. It's just amazing. The diabetic foot has really allowed entrance into a world that podiatry hadn't been in previously in many instances.
Well, it's not just the diabetic foot; it's the competency. There are folks out there that I don't think should be doing this work. That is fewer and fewer in number because of how we are now training our residents, and the degree at which our trainees, our trainers, are so competent in what they're doing that they're able to then transfer that knowledge so that we are indeed the surgeons of the foot and ankle. And I mean, it wasn't always age. As for a while, we were sort of a juvenile delinquent. But now we are blossoming into a young adult, competent and confident and able to take on these tasks. And most importantly, understanding what our limitations are. Asking for help when you need it and getting it. We have so many instances in the VA, especially because everyone's together. Podiatrist amputation. We might be doing the I&D, delayed primary closure. The vascular surgeons are doing the distal bypasses so they can heal, and veterans are saving limbs. And so they're walking on, sometimes they have a partial amputation, but they aren't getting the BKs and the AKs to the same degree that they were in the past.
That's awesome. Now, you started a national push for amputation prevention called FAVE, right? Oh, what was it? Close. What was it again?
Close. And I can't take credit for it. So this in 1992, Congress determined that the VA needed to address the high amputation rates in veterans with chronic diseases, diabetes, chronic kidney disease, peripheral arterial disease. And so they developed, the VA developed what was called at that time the PACT program, PACT, which stood for Preservation, Amputation, Care, and Treatment. And it was a combined amputation prevention and amputation care program. That sort of has morphed over time. So when I took over in 1997, it lived in prosthetics and specialty aid services, which is the rehab side, not the prevention side. So at the time, Fred Downs, who was just a phenomenal guy, he was a Vietnam War vet, a single arm amputee, and was in charge of prosthetics and sensory aid services. And I sat down with him and I said, this doesn't make sense to me. He says, doesn't make sense to me either, but no one else would take it. And so being an amputee myself, I wasn't going to let it drop. And I said, well, I don't want to wrestle it away from you, but I really believe that this belongs in the prevention side. He says, it does. Let's do this together. And then once we get this established, then you'll take over. And so Fred Downs really was the individual who started this program and sort of the grandfather of VA amputation prevention. I took over in about 2099, 2000, something like that. And then we started writing various directives and improving the program. So there's been 7 iterations of the directive starting back in 93. We added the requirement that all patients with those disorders, diabetes, chronic kidney disease, peripheral arterial disease, and also sensory neuropathy of any cause, were identified as PAVE patients. PAVE stood for Prevention of Amputations, Veterans Everywhere. And those patients had to be screened on a yearly basis in primary care. And then based on the foot risk score, they were properly and timely referred. So if they were a 2 or a 3, it's a 4-point scale, 0 being normal risk, 1 being low risk, 2 being moderate risk, and 3 being high risk. They were a 2 or 3, estimated to be 2 or 3. They had to be referred to podiatry for an exam and the final determination. And then they were placed on a regularly scheduled basic foot care and surveillance program in order to do the amputation prevention. And I will say that, because it's not just me, but it's all of the folks out there that are doing the work, that the VA has the benchmark in amputation prevention programs in the United States. And with that said, still, sorry about that. Are you back?
Yep, I'm back.
Okay, good. And with that said, we are still amputating too many limbs. So Berwick and Don Berwick said once, every system is perfectly designed to get the results that it gets. And so our system is really good, but we are still not there yet. We're still at maybe 90%. We still have 10% to improve. And if we knew how to do amputation prevention every time, there'd be one way to do it. But we don't. And we don't because there's a variable that we can't account for, and those are the patients. So we get them at various stages. Obesity, diabetes, poor nutrition, lack of exercise, smoking, and so on. We can't control these. One of those patients gets screened for the risk factors and get a timely and appropriate intervention so that we can do the best that we can. So we don't measure our amputation prevention program just on amputation rates. We actually measure it on the major-minor amputation ratio and the AKA, or above knee and below knee amputation ratios, which speaks to, once we do get the patients, how effective are we in preventing the more proximal amputation? Because we know, everyone knows that there are a certain number of amputations you can't prevent. So the real measure of that prevention program is, are you preventing the more proximal amputations? And we have been trending down for 22 years in terms of that. So we're proud of that, but the work's not done yet.
No, it's always a work in process. But you know what? That's fabulous, Jeff. And I kudos to you and your team throughout the VA in the United States, because it's going to continue. I mean, we have more patients with diabetes. We have more patients that aren't under appropriate control. We're going to see neuropathy. We're going to see peripheral vascular issues. So it's hard to stay on top.
Yep, that's exactly right.
So within the last, what was it, 5 years, how long have you been pushing for parity for podiatric physicians at the VA?
It's 97.
Since then, okay. Let's talk about there's been some landmark decisions in terms of podiatric medicine in the VA. Do you mind commenting on that?
Sure. So, and I also want to, I'm going to preface this by talking a little bit about the educational process. I'm going to go back to the late 50s. Now, I was a young kid then, but the history is I still know the history. Podiatrists got prescription rights in the late 50s, early 60s. We got them because our educational system taught it, and taught it to the same degree as they did in medical school. And that was not lost on the educators, the people who were in your position now that were in those positions then, and they realized that we needed to standardize. It took us some time to standardize, about 20 years, 25 years, to really standardize it because there was a lot of pushback and what have you. But what that allowed us to do is to get on a track of competence, and which is what I was speaking to before. So in 97, when we pushed for surgical privileges, we did it under the guise of competence. Not, I'm a podiatrist, I have a degree, I should be able to do surgery. No, I'm well trained, I know how to do this, here are my results. It's different. Now the interesting thing was that in the VA system, there was no professional prejudice. We were considered equal in terms of our skills, what we did. There was none of that professional prejudice stuff. But I couldn't explain our training programs fast enough for them to understand. So we, if you remember, if we had an RPR, a rotating podiatric residency, a POR, podiatric orthopedic residency, a PSR 12, a surgical residency, a PSR 24. That's a lot of, and a PSR 36. That's a lot of acronyms. I couldn't explain it fast enough. When we went in the mid 2000s to a single training model, they immediately understood what it was. I didn't have to tell them. I didn't have to show them. We have a PGY1, PGY2, in some cases PGY3 early on. Now it's all PGY1, 2, and 3. They said, oh, okay, so the first year is a general rotating, and second year and third year you specialize in your whatever the specialty is. Yes. I didn't have to tell them. They told me. They understood. Why? Because it looks like them. That's what they did. So as we started to look, our training program started to look more and more like medicine, and they were, the parity issue was just a matter of time. Now, I was writing legislative proposals to move podiatry to the same pay bands as other physicians and dentists and to be defined as a physician. It happened in 2018. Now, the reason that it didn't happen because I wrote legislative proposals. It didn't happen until we were able to convince APMA, which, by the way, we had to convince them that this was their fight too, but we did, and they took up the mantle. And thank God for Ben Wallner, who is a lobbyist for APMA, done a phenomenal job. And he, President, while he was doing this, were really responsible for moving this. And of course, Congressman Winstrup. Yeah, it was absolute kismet. Absolutely. Without him, to support the bill and actually write the bill, we might still be in this situation. But we're not. So things sort of lined up. The stars aligned. He wrote the bill. It didn't go through the first time. As you may or not remember, the first time it went out, it didn't go through. It just sort of died on the Senate side, and then it was reintroduced. And of course, it was reintroduced as part of the Mission Act, and Section 502 of the Mission Act, and was passed in 2018. So for me, the really exciting part of that is that not only did it move us to the same paid bands as other physicians and defined us as physicians, but it also allowed us to assume the same leadership positions as any other physician, dentist. And so each one of these podiatrists who up until this point would not have had the opportunity to even apply for those positions, not only applied, but got them. And that to me is so remarkably exciting to me to see that actually happen and to continue to grow. That's
incredible. And kudos to you. It happened under your watch. And I appreciate you give a lot of credit to Ben, and Ben's awesome, and the senator. But I mean, it's all hands on deck kind of opportunity for our profession.
Well, it is the thing that I describe myself as being benevolently aggressive. And it's something that I don't allow myself to get frustrated when something doesn't happen the way I think it should happen. If I think it's important enough, I will continue to fight for it, to move it forward. If it doesn't happen on my watch, hopefully the people that stand on my shoulders will be able to take it to the finish line.
That's fabulous. So just a couple questions on the side. How many residencies are there right now throughout the country in podiatric medicine at the VA? At the VA, there are about 35 to 40. It's hard to keep track because that's something else that we were able to do in the last 5 years, and that is to get the disbursement authority. So very quickly, for those that don't know what a disbursement authority is, the way medicine and surgery in the MD and DO world do that in the VA is that they affiliate with another medical institution. So in Cleveland, it's Case Western Reserve. And Case Western Reserve is the sponsor of the residency program, and they affiliate with the VA for that clinical component part of the program. And the VA disperses the money to the institution for the time the residents spend there. Now, up until 5 years ago, we weren't allowed to do that. And so the pay structure for VA-only podiatric residency program was much, much less than what CMS was paying in the outside. So we finally got that authority, and we are now in the process of converting several of the programs. We want to convert all of them. Some we will, some we may not. But so far, about a quarter of our programs have been converted to this new model, and are doing quite well and able to provide the residents with the same salary structure that other podiatric residency programs get. I think that happened in Denver also at Denver Health.
Yeah.
That's just a phenomenal opportunity for the attendings and the residents and the students. So I think that's a great model going forward.
Yeah, we're very excited about it and continue to promote it and push it. But that doesn't mean that all the programs will be able to do that. I mean, we do have some hospital systems that are in remote areas where they're just not going to be able to affiliate with institutions to do that. So we'll continue to fund those.
It makes sense that those numbers are a moving target. I totally understand that. That's great. All right. So Jeff, what's interesting about this is I've never been involved with the VA. I trained at the VA as a student doing rotations and things, but unless you're involved in the VA, I'm not sure how anybody would know all this information you've been sharing. So thank you.
You bet. My pleasure. All I have to do is ask me. I'm happy to talk.
No problem. Hey, let's move on to another topic, though, a little bit not podiatric medicine. I noticed all of your guitars in the background, and you and I had a great opportunity to sit down and talk when we were in Nashville at the national meeting, and you shared some phenomenal stories about your music background. Do you mind sharing some of that with our audience?
Sure. Well, first of all, I'm still in a rock band, and we still perform. We're a cover band. We do 50s, 60s, mainly 60s, 70s, and 80s music. Things Beatles, Rolling Stones, Ides of March, Paul Simon, Creedence Clearwater Revival. I mean, all the bands that the Queen that you would think of, Motown stuff. It saves me thousands of dollars in therapy, but it's very rewarding. And the other thing that I found is that it seems that a lot of folks that go into medicine, and I always found that really, really interesting. Our band actually has our primary care physician is our trumpet player. Our lead guitarist is an oral surgeon. I am rhythm guitar and lead vocals. We have 2 attorneys. So it's a professional band, and it's a great joy. It really is. It's a wonderful avocation, and it's been a lot of fun. We've had the opportunity to do some really, really unique things. Just last January, we played at Severance Hall in Cleveland, which is where the Cleveland Orchestra and the Cleveland Pops Orchestra plays. Carl Patopoulo, who is a good friend of mine, is the conductor of the Cleveland Pops Orchestra, and he invited us to play New Year's at right after the Pops played, and it was quite nice. It was a lot of fun.
That's great. Now, you had an opportunity one time to play before one of your musical heroes, right?
Oh my God, yeah, that was really something. So we were asked to do a benefit for a community college, and the philanthropist who was putting it on called me up and he said, "I have a friend who likes to sing. Would you mind if he sang with your band?" And I said, "I don't do this for a living." "Absolutely, that's not a problem. We'd be happy to have him." He said, "Well, let me check to see if he can come." I said, "All right." So I told my bandmates that, and they said, "Yeah, that sounds fine." So he calls me back and he said, "It turns out he can come, and I will have Mr. Avalon send over his charts." And I said, "Excuse me, Mr. Avalon? You mean like Frankie Avalon?" He says, "Yes, he's a very good friend of mine, and he comes to Cleveland once in a while, and he'd be happy to sing at the with." And I went absolutely wild. So they sent me the charts. We did 3 songs with him: "Why," "Venus," which was the #1 hit in 1959 in the world, and then "Beauty School Dropout" from Greece. So I went to tell my band. I said, "So this guy's friend can play, and but you're not going to believe who the friend is." And he said, "Well, who's the friend?" And I said, "Well, it's Frankie Avalon." I said, "Come on, get out of here, Frankie Avalon." So I passed out the charts, and they went absolutely wild. And I have to tell you that he was the most delightful guy. It was a pleasure meeting him. He was a hero. I watched all of his movies. I liked his music. And he was just very generous and very kind. And what you would hope that your hero would be. He wasn't arrogant. He wasn't any of that stuff. He was gregarious and he was friendly. And I remember meeting him. I saw him walking with a friend of mine who owned the venue. And I came off the stage and she introduced me to him. And I said, "We share something in common." He says, "What's that?" I said, "Well, I did my residency program in Philadelphia." He says, "You're from Philly?" I said, No, I did my residency program there." I said, Where'd you do it?" I said, "At St. Luke's and Children's Medical Center." He says, "You mean with James Giuffre, the smoking surgeon?" I said, "Yeah, yes, as a matter of fact, yes." He said, "Well, he took my gallbladder out." I said, "That's awesome." He said, "Wait a minute, I don't understand something. You're a doctor." "Yeah." "What are you doing with the band?" I said, "Everyone needs a hobby." He says, "That's awesome. Come on, let's go practice." So I gave him a microphone, and he is standing there, and I am playing for Frankie Avalon. And he is singing to me and the band, but he's singing directly to me the music that I'm playing back to him. And it was like an out-of-body experience. It was just so much fun.
That is just an incredible story. So, Jeff, if I was to throw a big party and have your band come in, what would be your 3 favorite songs if you had a 3-song set?
Ooh, a 3-song set. So probably Late in the Evening by Paul Simon, Crazy Little Thing Called Love by Queen, and Make Me Smile by Chicago.
Chicago and Paul Simon are 2 of my absolute favorite bands.
Yeah, and I did not know that.
No,
that wasn't part of our discussion.
What other Chicago songs do you sing?
We do Beginnings. We do a medley of a song by the Grassroots called Temptation Eyes and 25 or 624. The introduction to both songs, so we go from Temptation Eyes to 25 or 624, and we end back with Temptation Eyes.
Oh my gosh, how fun is that?
Oh, it's great.
Oh, that's
awesome.
Great.
Yeah.
So that makes you must have been a blast to work with in the operating room, singing songs and playing music.
I didn't do that much. While I do have the guitars, I do play some solo stuff. I love having a band around me. It hides a multitude of sins.
I hear you. No, it's just a fabulous story. Well, Jeff, I want to thank you so much for joining me today, but also for all the great things you've done for our profession. I've learned a lot today because I didn't know all that history about the VA, so thank you.
You bet. And thank you for what you're doing. You have the opportunity to make a difference, and you are. I've talked to some of your students who have rotated through various places in the VA, and you're doing a great job training the next generation of podiatrists, and keep it up.
Like you, I got that opportunity to try to make the most of it, right?
There you go.
All right. Thanks again, Jeff. By the way, I'm going to send you one of these Dean's Chat cups. And
cool.
That way we can remember our discussion. And I'll keep thinking of some more 3-song sets I'll run by you. How's that sound?
Sounds great.
Okay, sounds good. To all of our listeners out there, thank you so much for joining us today. If you're listening on Apple Podcasts or Spotify, please give us a 5-star rating. And if you're on YouTube, by all means, become a subscriber. And until next week, cheers, everybody. Jeff, that was awesome.
That was fun.
Oh my gosh, thank you. I love that story. I just love the stories. Oh, Chicago, I was watching a bunch of history of the band on YouTube, and it's incredible how they were playing in Milwaukee, and they were rebels, and they didn't want to play the songs of the day. They wanted to play their own music, and how they had to move to LA and live in a house and create all their music. I mean, I just love Chicago.
So there's a caveat to that. So at the time, and this is 1968 through 75, there was another band called Blood, Sweat, and Tears.
Yeah, yes, I heard about this.
So Blood, Sweat, and Tears, who I thought were better musicians than Chicago. Now, I love both of them. I thought both of them were great. But Blood, Sweat, and Tears, their music was much more complex and sort of jazz, pop, fusion, rock. I mean, it was very, very, very complex. And they did some older stuff. They did God Bless the Child and Spinning Wheel, which were songs that...
You make me so very happy. Is that one of them? Or you make me so happy?
Yeah. I'm drawing a blank on her name. But at any rate, there's a movie out called, pardon my language, What the Hell Happened to Blood, Sweat, and Tears? And I didn't get a chance to see the movie. I actually have it reserved. Apparently, there's some CIA connection with the band that they were blackmailed into going and doing a concert in Russia, if I have the story right. And they did the concert there under duress. But when they came back, no one wanted them. The right didn't want them because they went to the Soviet Union, and the left didn't want them because they went to the Soviet Union. And they just sort of petered off. And so if you get a chance to see this movie, I think you'll enjoy it. I haven't seen it yet, but that's the basic story of what the hell happened to Blood, Sweat, and Tears. But David Clayton Thomas, who had a great voice, and we do one song. It's not his voice, though, and it's not him. It's a song called Vehicle by the Ides of March. And if you listen to it, it sounds just like his voice, but it's not. It's not his voice. But we do that song as well.
Oh, that's awesome. All right, Jeff. Well, hey, I'll let you go. We'll get all this edited, and then I'll let you know. We'll get it up on YouTube and Spotify and everything over the next few weeks, probably.
Sounds great.
And it's so enjoyable. Thank you so much.
My pleasure.
Okay. All right. Talk to you soon, then.
Sure. All right.
Bye. Bye.